All right, let's dive into one of the most critical and frankly high-yield topics in neurology, brainstem stroke syndromes. If you really want to master localization, this is where it's at. The key to unlocking all of this, the absolute hallmark we're going to keep coming back to, is a concept called crossed hemiplegia. It's our guiding star through this whole review.
So here's our game plan. We're going to start with the basics. What makes a brainstem stroke unique? Then we'll introduce a really powerful mnemonic, the rule of 4. From there, we'll take a systematic journey, level by level, through the midbrain, the medulla, and the pons, before we wrap it all up with the most important clinical takeaways.
Okay, first things first. Before we can pinpoint a lesion in the brainstem, we have to know where in the brainstem to begin with. That means knowing how to distinguish it from a lesion way up in the cerebral cortex. This is step 1, and it is absolutely essential for getting the diagnosis right.
And that brings us right back to crossed hemiplegia. So what is it? It's this strange-sounding situation where you have a cranial nerve problem on the same side as the lesion, but body weakness on the opposite side. Now, why does this happen? Well, it's all about the wiring. The cranial nerve nuclei, their lower motor neurons supply structures on the same side of the head. But the big motor highways, the corticospinal tracts, they travel down through the brainstem and only cross over much lower at the bottom of the medulla. That's the secret. A single lesion can catch both sets of wires before the big one crosses.
Here's how that plays out clinically. With a typical cortical stroke, everything is on the opposite side of the lesion. The face is weak, the body is weak, all contralateral. But in a brainstem stroke, you see that split. You get an ipsilateral, lower motor neuron-type cranial nerve palsy paired with contralateral body weakness. When you see that crossed pattern, you have to think brainstem. It's the pathognomonic signature of a brainstem insult. Now, how do we get more specific than just somewhere in the brainstem? This is where we introduce an incredibly elegant tool for localization, the rule of 4. This mnemonic is a game changer because it helps organize the brainstem's anatomy along its medial lateral axis, letting you predict the clinical signs just based on where the lesion is.
Let's break this down. The rule splits key structures into 4 medial M's and 4 lateral S's. Running down the midline, you've got your motor nuclei for eye and tongue movement. That's nerves 3, 4, 6, and 12. You have the medial longitudinal fasciculus, or MLF, the medial lemniscus for sensation, and of course the big motor corticospinal tract. Now, out to the side or laterally, you have your S structures, the spinal thalmatic and spinal cerebellar tracts, the sympathetic fibers, and the spinal nucleus of the trigeminal nerve. Why is this so powerful? Well, it immediately tells you why a lateral lesion like Wallenberg syndrome characteristically spares motor function, and why a medial lesion spares pain and temperature sensation. It's all right there in the rule.
Okay, let's start our tour at the top of the brainstem, the midbrain. First, we're going to build a quick mental map, a cross-section, to get our anatomical bearings. Once we have that down, it'll be much easier to understand the ventral syndromes, which are usually from strokes of the PCA, and the dorsal syndromes, which are often caused by tumors putting pressure on the back.
So let's picture a slice through the midbrain. At the very back, you have the tectum, or the roof. The big central area is the tegmentum, and this is where you find really important stuff like the red nucleus and the oculomotor, or third nerve, nucleus. Then, way out front, you have the crus cerebri, which is basically the massive corticospinal motor tract packed into its middle 3/5. And separating the tegmentum from the crus cerebri is the substantia nigra. Now that we've got that map in our heads, we're ready to look at the syndromes.
This table lays out the classic ventral syndromes. First up is Weber syndrome. This is a lesion in the crus cerebri that hits the third nerve fibers in the corticospinal tract. The result? An ipsilateral third nerve palsy with contralateral hemiplegia. Classic crossed hemiplegia. Now, Claude's syndrome hits the tegmentum, so it gets the third nerve nucleus and the red nucleus. That gives you an ipsilateral third nerve palsy with contralateral ataxia and tremor. And Benedict syndrome, it's basically a bigger lesion that gets you both Weber and Claude, and then adds in contralateral hemichoria because it's also affecting the substantia nigra.
Now let's flip around to the back of the midbrain to talk about Perinaud syndrome. This one is different. It's usually not a stroke. The classic cause is a pineal gland tumor pressing on the pretectal area. And the signs are so unique. You get a vertical gaze palsy, especially for upgaze, which causes the sun setting sign, where the eyes seem to set below the lower eyelid. You also see pupils that accommodate but don't react to light. That's light near dissociation. Then there's lid retraction, or Collier sign, and this bizarre convergence retraction nystagmus when they try to look up. It's a very distinctive collection of signs.
And then there's Noth-Nagel syndrome. You can think of this as a variation of a dorsal midbrain lesion that just extends a bit more forward. So it has the upgaze palsy you see in Paranod, but it adds two critical new features: an ipsilateral third nerve palsy, because the lesion has reached the oculomotor nucleus, and contralateral ataxia, because it's hitting the superior cerebellar peduncle fibers as they cross nearby.
Okay, let's head down to the caudal brainstem, the medulla. Lesions here can be catastrophic, and I have to say, being able to clinically tell the difference between a lateral and a mediomedullary syndrome is probably one of the most important localization skills you can have in neurology.
Let's unpack the famous lateral medullary or Wallenberg syndrome. Think back to our rule of 4. This is a lateral lesion, so we're expecting all the S structures to be involved. And what do we see? Ipsilateral facial numbness from the spinal nucleus of V, vertigo and ataxia from the vestibular nuclei, trouble swallowing and a hoarse voice from the nucleus ambiguus, and ipsilateral Horner syndrome from the sympathetic tract, and the only contralateral finding is a loss of pain and temperature in the body thanks to the spinothalamic tract. Notice what's missing? Motor weakness. The corticospinal tracts are medial, so they're completely spared. It's a perfect example of the rule in action.
Yeah, in complete contrast, we have the medial medullary or Desjardins syndrome. This is a lesion of our medial M structures. The classic presentation is an ipsilateral 12th nerve palsy, so the tongue deviates toward the site of the lesion. Then, on the contralateral side, you get hemiplegia from the corticospinal tract and loss of proprioception and vibration from the medial lemniscus. Sometimes the medial longitudinal fasciculus can be involved too, which can lead to an ipsilateral internuclear ophthalmoplegia, and that's a concept we need to unpack right now.
So to understand these next syndromes, we have to trace the complex pathway that makes your eyes move together. Let's say you want to look to the right. The command actually starts in your left frontal eye field. That signal shoots across to the pons on the right side and hits something called the PPRF, which is the horizontal gaze center. The PPRF then tells the right sixth nerve nucleus to fire, which abducts the right eye. But at the exact same time, a yoking signal has to travel up the left medial longitudinal fasciculus to tell the left third nerve nucleus to fire, which adducts the left eye. It's this beautiful coordination that keeps both eyes on target.
So now imagine what happens if you have a lesion that cuts that MLF wire. That's an internuclear ophthalmoplegia, or INO. If you take out the left MLF, the signal to adduct the left eye never arrives. So when the person tries to look right, the left eye just doesn't adduct. It can't move inward. Meanwhile, the right eye, which is abducting just fine, gets this compensatory nystagmus. That's a classic INO.
Now, building on that, what if you have a bigger lesion that takes out both the PPRF and the MLF on the same side? You get the 1.5 syndrome. Let's say the lesion is on the right. Taking out the right PPRF means you can't look to the right at all. Both eyes are frozen. And the coexisting MLF lesion means the right eye can't adduct when you try to look left. So what's the only horizontal movement left? Abduction of the contralateral, or left eye. You've lost 1.5 of the 2 horizontal movements.
All right, we're now moving into our last major section, the central brainstem, or the pons. The syndromes here can get a little tricky, so we're going to focus on the most clinically important ones, which are typically caused by strokes in the territory of the basilar artery.
Thankfully, we've got some pretty good mnemonics to help us keep these straight. In the ventral pons, there's Millard-Gubler syndrome. You can remember that with FSH, ipsilateral facial and sixth nerve palsies with a contralateral hemiplegia. Raymond syndrome is just SH because it spares the facial nerve. Move to the dorsal pons and you get Fauville syndrome, which is FGH, ipsilateral facial palsy and gaze palsy with contralateral hemiplegia. And finally, out in the lateral pons, Marie-Foix syndrome is ASH, ipsilateral ataxia with contralateral spinothalamic sensory loss and hemiplegia.
And that brings us to locked-in syndrome, which is one of the most devastating conditions in all of neurology. This is what happens when you have a massive bilateral stroke in the ventral pons. It completely wipes out both corticospinal and corticobulbar tracts. The result is total quadriplegia and anarthria. The patient can't move and can't speak. But, and this is the crucial part, the ascending reticular activating system, which is more dorsal, is spared, so consciousness is fully preserved. They are awake and aware, but locked inside their own body. The only voluntary movement they have left is vertical eye gaze, because those control centers are higher up in the midbrain.
Okay, we have covered a ton of ground. To wrap this all up, let's distill everything down into the most critical, high-yield concepts you absolutely need to have in your back pocket for recognizing these posterior circulation strokes in a clinical setting.
And this leads us to a vital clinical heuristic. When you're evaluating a patient with acute neurological symptoms, especially if they don't have that classic motor weakness, you have to be thinking about the 5Ds. These are huge red flags for a posterior circulation stroke. So what are the 5Ds? Dizziness, and we mean true vertigo. Dysarthria, or slurred speech. Dysphagia, difficulty swallowing. Diplopia, double vision. And dystaxia, which is just another word for ataxia, or incoordination. If you see any combination of these symptoms, your suspicion for a brainstem or cerebellar stroke should be sky high, and that patient needs urgent attention.
So I want to leave you with a final question to really synthesize everything we've talked about. We know that small lacunar strokes deep in the brain can cause a pure motor or a pure sensory deficit. But the brainstem, it is an incredibly compact and densely packed structure. You have all these ascending and descending tracts, all these cranial nerve nuclei, all crammed together in a tiny space. So given that unique anatomical arrangement, why is it that a vascular lesion in the brainstem almost never produces a pure deficit, but instead gives you this complex mix of signs and symptoms? It really gets to the heart of why brainstem anatomy is so important.